So welcome to everyone who has joined us for our second webinar in the Contemplative Medicine Conversations series. My name is David Iozzi, and I'm the Director of Studies for New York Zen Center for Contemplative Care, and I'll be facilitating this event with support from our online programs manager, Meier. Today, the co-founders and co-guiding teachers of the Zen Center, Sensei Chodo Robert Campbell and Sensei Koshin Paley Ellison, are joined by Dr. Diane Meier. And I'll speak for many of us and say how excited we are to have you joining us, Dr. Meier. Dr. Meier is Director Emerita and Strategic Medical Advisor at the Center to Advance Palliative Care, also co-director of the Patty and J. Baker National Palliative Care Center, professor, the Department of Geriatrics and Palliative Medicine, and Catherine Yaseman, Professor of Medical Ethics at the Icahn School of Medicine at Mount Sinai. So I'm excited to hear what you three are going to be talking about. While director at the Center to Advance Palliative Care, which is a national organization devoted to increasing access to quality healthcare here in the United States for people living with serious illness. Under her leadership, the number of palliative care programs in the US tripled since 2002. And if you've seen some recent articles where she's been interviewed, you've probably seen the impact of palliative care and the need for it, especially now in this time of pandemic, and also the extension of that approach to meeting the suffering of patients being so important in every aspect of medicine, not just with serious illness. And I hope we'll talk a little bit about that today. She was also named, I hope you're okay with me going on and on about you, Diane. She was also named one of the 20 people who make healthcare better in the United States by Health Leaders Media, and has been published many times, 200 or so times, in peer-reviewed medical journals. And her most recent book, Meeting the Needs of Older Adults with Serious Illness, Challenges and Opportunities in the Age of Health Reform, was published by Humana just in 2014. So welcome again. And this second event of the Contemplative Medicine Conversation series is entitled The Gift of Human Presence. And this evening, we'll be talking about how, or we hope, we invite you to talk about how contemplative practice is a critical support to clinicians who wish to foster and sustain deeper connections with patients, with team members, with families, loved ones, and themselves, actually, in this time of pandemic. So the format for this evening is a free-ranging and I'm sure dynamic conversation. I won't be asking questions as I might with a panel. I'm just going to turn things over to the three of you to talk about the gift of human presence and contemplative medicine. For people who are here, we'll be taking questions through the Q&A feature. Please use that to chat those questions in. Meier and I will be monitoring it, and towards the end of the conversation, we'll pass those questions that haven't been covered in the conversation. I'll be presenting those. And I think that's all in terms of Zoom housekeeping. So Koshin, Chodo, and Diane, welcome. And perhaps we could begin with you sharing a bit about how the three of you find yourselves here together talking about contemplative medicine.
Diane. Yeah,
I responded to an invitation from my friends, and we've known each other how long now? 15 years? 20 years? A long time, and have worked together in various of the educational initiatives that you guys initiated and led, and the alignment or overlap or hand-in-hand nature of contemplative medicine and palliative medicine is really profound. And I think both fields nourish each other.
How do you see that, Diane?
Well, I wouldn't say that palliative care is more mainstream than contemplative medicine. I mean, one might wish that it is, but it probably isn't yet. But there's a medical specialty in palliative care and a nursing specialty, and 94% of large hospitals have palliative care teams. And so the understanding of and access to it is much better than it used to be. And despite the fact that many people don't understand what it is or misunderstand it as brink of death care, the essential principles and practices of palliative care are those of contemplative medicine. They are a sort of I-thou stance of the clinician with the patient, and the discipline and self-awareness necessary to kind of put aside the time of the day and all the other things that happen before you encountered this fellow human, this patient, and to bring the discipline of being fully present. Because if you don't do that, you can't make any difference. You can't help. And the core of the intervention, the core of the benefit of palliative care is the practice of helping the patient feel seen and recognized as a rich and complex person, not the case in bed 27, the object of procedures and multiple specialists, but to restore that person to themselves through our relationship with that person. And that is not something we're born knowing how to do, which is why I think that the practices of contemplative medicine are so essential to palliative care. And I hope that the growth and expansion in access to palliative care serves the same role for contemplative medicine.
Mm-hmm. It's so amazing because I feel like in many ways, the palliative care and to palliate is to relieve suffering. And I think what we're looking to do also is to bring together, how do we relieve the suffering also of the primary, as we've come to know them as frontline workers. And so the palliative care clinicians themselves and all the clinicians themselves, like how do we palliate that? And so that we can have one life, where there's often this sense of a work-life disconnect or feeling that they're not feeding one another or they're not even relating to one another.
Right.
As we often hear this, expression of we're teaching doctors, whether here or in Japan, that the doctors are talking about, oh, I'm so bad at my self-care. I know I should do my self-care. And it just becomes like another thing that they have to do. And really for us, and part of contemplative medicine is really looking at just there's care. And so the care that you're offering is also the care that you're offering yourself. And so there's no self-care and then other care.
Right, exactly. Well, I think if you asked any clinician in a moment of reflection, where the joy is in the practice, and where the sense of I'm in the right place, I'm doing the right thing, this is what I was meant to do comes from. It comes from that profound human connection with our patients. And if we can't have that, or if we cave to the pressures that try to take it away, we give everything up. And I think we're actually seeing the consequences of the incredible time and volume pressures that clinicians are under, independent of the pandemic, that was maximally magnified by the pandemic. And it became, the pressure became so intense that it became impossible to pause, to be with, and look full in the face at our patients. And I think this is why so many people are thinking about leaving clinical care, because the one thing that is nourishing about it, the one thing that is inspiring and strengthening and joyful about it, has been tossed as unimportant, because we have a medical industrial complex where volume is king. So, so yes, to your point that this is not just about healing patients and their families, it is very much about healing ourselves.
I was thinking as we were at the very beginning, when Diane asked the question, when you asked the question, how long have we known each other? It's like 15 years, if not more. And my mind went back to the time when Koshin and I, as two Buddhist monks, walked into a hospital. It's always like a joke. Two monks walk into a bar. Right? Two monks, a doctor and a palliative care doctor, walk into a bar. And I remember Koshin and I walking into the hospital saying, here we are, these two monks, and we have this idea about bringing contemplative care onto the floors. People were like, what? Zen? We don't need Zen. Bringing Zen, we're bringing in a different way this is where we're beginning in hospice, but a different way for caregivers and doctors to relate to patients, to remind them that actually, you know how to do this, you've just forgotten.
Yeah.
You were born, you knew how to do it, you grew up, you forgot it. So, and now we're in this irony of, during the pandemic, it was needed so much more, right? And maybe this is a moment for clinicians to fully comprehend that, you know what, I do need to face my own issues around mortality. I do need to be with patients in a different way. I need to be with myself. My understanding of medicine is like being blown up. Because think of all the doctors, clinicians that were not able, David talked about human presence, the importance of human presence. All those doctors and family members that were not able to actually be in the room with COVID patients who were dying.
Exactly.
This is kind of like, okay, get up off your ass and really think about this stuff now.
Yeah.
This is a perfect time to be looking at it.
I think one of the things that has struck me hardest and has stuck with me through the pandemic's sine waves is the ways in which our colleagues who don't work in palliative care turned to us to fulfill their sense of what good healthcare should be like, right? That it should include seeing people as persons, with lives and feelings and ideas and relationships, And because our colleagues could not do that because of the sheer deluge of very, very sick people, they were able to enact that desire by working with their colleagues in palliative care. It's very interesting. I heard an interview with the guy who ran the pandemic response for one of the big Harvard hospitals or health systems. And the reporter asked him what he needed, thinking he might say something like, PPE or masks or more doctors or more nurses. He said, the only thing I need more of is palliative care. So I think the pandemic kind of exposed the chasm between the machinery of the healthcare system and the genuine essential needs of human beings for one another and for being seen as people. And when you think about the pandemic, not only for many people was it, very sudden, unexpected, devastating illness in a very short period of time, totally cut off from the people they love. And talk about loss of identity and not getting a moment to adjust to the impact of illness on identity and sense of meaning, sense of self, sense of purpose. The ability of clinicians to remind our patients that they are still a precious person that we see and want to be with and learn about is really powerful, really powerful. And I think a lot of people who don't work in palliative care learned that and realized it because of the pandemic. One of the silver linings.
I think the pandemic has heightened the awareness for doctors and clinicians of just how important presence is.
Yeah.
I think so.
Exactly.
One of the things I was also thinking about was something that has become so clear to us during this time, and was our mutual friend Russ Portnoy. Many years ago, he was saying to us, like, you guys, this is after the two monks walked into the hospital, and we worked with Russ directly for many years and on his team. And he said, the Buddha actually wrote the palliative care prescription, that there's suffering, that there's a cause of the suffering, which is different than pain, and that there's a way out, and that you can actually do that through community, through presence, and through meaning. And so it was so amazing, because for us, we kind of forgot. And we're like, oh yeah, that's actually a great point. And and many times I think during this pandemic, what we've seen is this, how important community, meaning, and connection are.
Yeah.
How we really need each other as clinicians, as people who can really help each other to rekindle that joy that you talked about.
I mean, you talked about meaning. The meaning of life is in relationship. And if we take that away because we're trying to protect people from infection, and because we can't handle the volume of need, what's the point? And I think there is a sense of loss of grip on what the point of life is. And we have to consciously restore it. And at its best, the practice of medicine, the delivery of healthcare, is about reaffirming the social meaning and value of the patient's sense of self. we've let it become something much more mechanistic and contingent on, a test or a treatment. But that relationship compensates for the broken connections that illness imposes, or it can, if it's practiced well.
So Koshin and I, we were vaccinated. Is it vaccinated or vaccinated? Vaccinated. We were vaccinated in a hospital up in Upper Manhattan that serves the underserved community in New York. And it was so interesting, the stark difference of walking into that hospital where the nurses were so incredibly present,
Loving.
and loving. And we actually asked one of the nurses who was delivering the vaccine, I asked the vaccine, delivering the vaccine to me, it's like, you're in such a good mood around this hospital. She said, we've seen so many people die over the last year. She said, what's the point of not being engaged? What's the point of not being fully with you? And she was taking care of me, and she's, the whole thing. And she gave me a little boo-boo plaster at the end, a little thing. She said, this is what being a nurse is about. It's about being with you and giving you a nice Winnie the Pooh Band-Aid and sending you on your way. And
It was her loving presence, though.
to me, her loving presence to me, and it was reciprocal. I'm me asking the questions, what are you doing here? How are you getting through this? And then entering into this conversation, a palliative care conversation, palliating each other.
Yeah.
So beautiful.
And it's so interesting because so many people say, oh, I don't have time. But actually, I had this very similar experience with a different nurse, and it didn't take any more time.
Yeah.
It's about how they were looking at you, how they were in their own bodies. You could feel how they were in their bodies. They were relaxed and present and curious, and they were still getting it done.
Yes.
And delivering this loving medicine. So it's one of the things that got really inspired about thinking about what is medicine, and remembering like what that word even comes from, and what does it mean to be healing. Like what actually is medicine, as opposed to, as you were talking about, the healthcare industrial complex, but it's that it actually came from the very beautiful thing of what's healing, and how do we create houses of healing, and how do we offer good medicine.
Mm-hmm.
Yeah.
What's good medicine, Diane?
I found a quote that I want to read. This is by a guy named David Barnard, who I haven't seen in many years, and he published this in 1995. He's a kind of medical ethicist philosopher person. And he wrote, "The sting of illness and death is the specter of broken relationships and the loss of the world. Over and against this threat stand the efforts of caregivers and companions to embrace the sufferer and continuously reaffirm his or her capacity for relationship."
Right there, isn't it? That's it.
Good writer. Yeah. Yeah. I love that reminder, really, of what an incredible sacred privilege it is to help try to be with people who are sick, and how powerful presence and relationship are.
How have you seen palliative care change in the years that you've been doing it? What you've been teaching it, being it?
A lot has changed. I think most of the people who go into the field are driven or motivated by the things we've been talking about. One of the consequences of becoming popular in a way is again, too much work. Too many patients referred, not enough people to take care of them. And a sense, and here's where contemplative medicine is an incredibly important tool, a sense of not being able to be present in the way we would like to be because of volume pressures and time pressures, even in palliative care. And so one thing we need to do is establish quality standards that say you can't see 15 people a day. That's unacceptable. Just as we would say to a cardiac surgeon, you cannot do 15 cardiac surgeries a day. It's very similar. It's a safety and quality issue, right? And we need to get that codified better in order to protect people from fire hose of need, fire hose of suffering. And remember, we've got a group of people who chose this field because we are drawn to try to do something about it. So it's very hard to go home knowing there are 5 or 6 people you didn't see who need you at night, for example. So I think that's something I'm seeing a lot and worried about. The other thing I'm seeing a lot and worried about is the deployment of palliative care as a way to save money for the healthcare system. The usage, the exploitation, really, of palliative care because it is associated with less time in the hospital, more time at home, which is cheaper for the insurer or the healthcare system. And so there's this sort of, we're suddenly very, very popular with Medicare Advantage plans and Medicaid managed care plans and health systems that are trying to get control over high costs. And that's the wrong reason. And it really makes me nervous. Because if that's the reason you're hired and those are the metrics you're being held to, just as I am suggesting that the practice of medicine or the practice of healthcare has inadvertently thrown out its most precious and valuable capabilities, same thing is happening at a microcosm level in palliative care, that the pressures to achieve other people's agendas. We have to respond to that, or we won't be able to pay salaries or find jobs for people. But that tension is having a lot of strain and impact on people working in the field.
What kept you, I know I'm sorry, this is like Q&A between Diane and Chodo maybe at the moment, but what kept you, it could be worse, yeah. What kept you going?
The heart of it, the heart of it is what is right for the patient. And as long as we hold on to that true north and don't let other agendas supervene, I think I think about palliative care as a Trojan horse in the healthcare system. Right, so we got in by acting like everybody else. We're a medical specialty, we have fellowship training, we have board certification, we have nursing specialty, we have badges, we look like cardiology. And in so doing, we got in to Troy. And inside Troy, we're doing things very differently than how the rest of the culture is functioning. And I think it has don't know if the right word is a viral effect, but the mere presence of clinicians who do it differently has a kind of radical, revolutionary ripple effect. We have a long way to go on that, but I think it is very powerful. It's like saying the emperor has no clothes, right? Actually, it is about the human being in front of you. Actually, it is about understanding what's important to them. Actually, it is about trying to address suffering. And if somebody down the hall from you is doing that, even if you don't change what you're doing today, it gets in. And it reminds people of why they went to medical school or why they went to nursing school. And it gives them a choice.
And one of the things I was thinking about is, one of the reasons why we created this fellowship was because of this feeling and what we keep hearing from doctors about this depletion, about that many of the doctors we know other doctors who have killed themselves or having real struggling with drug and alcohol abuse or thinking about leaving the profession. A doctor I spoke to recently was saying, like, I feel like I have to do this, otherwise I'll have to leave the profession. And, so there's one of the reasons we were so inspired to create this fellowship was to really think about, like, well, what is the medicine that's needed? And what is your sense of what the medicine inside of clinicians that's needed?
Well, I think we sort of need to regain, I don't know, the word is not pride, but a sense of how our most essential instrument is our humanness. And do we also need skills, like, do we need to know how to do procedures or order antibiotics or manage heart failure? Yes, we need those things, but those are, you can look it up. You can get someone to show you. Healing comes through the relationship. It's very striking to me how, for example, many patients with cancer, they decline referral to hospice. And we all think it's because, or we react in a cliche manner, assuming that they're declining hospice because they're afraid of death and they don't want to acknowledge the reality of death. Actually, I think the major reason is they don't want to give up their relationship with their doctor. And that relationship is really powerful and meaningful. And has provided that patient with a sense of worth and value and being seen and being cared about. And we have this system where if you're not going to benefit from more chemo or more radiation, you're not allowed to see your oncologist anymore. Or at least that's the way people practice. And what we do inadvertently is abandon our patients at just the point when they most need us. And that's how we're training doctors. When there's, quote, nothing more that we can do, not our problem anymore. As if somehow that relationship that we built with that patient over the years that we took care of them is as nothing. So that's what I'm hoping we can restore by modeling inside teaching hospitals and in medical schools and in communities, remaining in relationship. I think many doctors don't realize they can continue to take care of their patients when they're on hospice. that they don't have to stop calling them or caring about them. They don't have to stop seeing them. It just isn't part of their training. So they don't know. But that's fixable.
Mhm.
So we need to fix that. Because what are we saying not only to the patient, but to their clinician? The relationship is unimportant.
I lead a weekly group coming to terms, and it's a group of 10 to 12 people, depending on whether they're in their infusion suite or they're too sick to come to the group. But they're all stage 4, and there's one man with ALS. And without exception, each of them have said how important it is that they are in touch with their doctor. And one particular woman has had 25 rounds of chemo because she wants to make sure she's around for her daughter's graduation. And the reason she's continued the chemo is because she trusts her doctor. She pukes, she lost her hair, the whole thing, she's gone through the whole thing. She's like, I trust him. And one couple of weeks ago, there's a lady at Dana-Farber getting her infusion, and the nurse came in and she said, this is my favorite nurse. She says, I love her. She sees me every time I'm here. So again, these relationships are not so difficult, and they're so incredibly important. Just be sitting in a group with women who are, these patients who are stage 4, they're not gonna come out of it, but they're so alive till we've had 2 ladies die in the last year, but the support that it's the group that's palliating each other.
Yeah.
And this is what's so beautiful. They're all at different stages in going through their own lives and their own transitions, basically. So,
But I think your point that the precious jewel, the thing that emerges from this struggle with serious illness is the relationship. And yet our healthcare system doesn't even notice it, much less value it, much less support it, much less sustain it. You could measure, sustained relationship as a quality measure. And we should. You talk about patient-centered care and patient satisfaction and what's important to patients. We know it's a trusted long-term relationship with a clinician. And to make the point, not necessarily an MD, or inclusive, far beyond the MDs on the team, just as you mentioned about your patient and her nurse. So
interesting too, because what you were saying earlier about that doctors aren't taught that they can follow their patients, right? And one of the things that we've been able to do here at the Zen Center was really be that continuity of care. So as people lose their primary care doctor, and then they lose their cancer doctor, and then they lose
just have to let the dog in, but I can hear you, so keep going.
And how important it is to provide that continuity of care, and actually what that does to the clinician, right? And what we hear again and again, even from palliative care teams, like, my goodness, like, whatever happened to that person? What happened to them? And what also you're saying is like, oh, you could send them a message, or you could
pick up the phone. Yeah.
It's such a beautiful moment of care. Excuse me, I had to let the dog in. I could still hear you. Right? So, but it's right there. I have to let the dog in. And you could just say that, but you said, and I could still hear you. That's a beautiful moment right there of being present to another human being, as opposed to just getting up and opening the door. Those are the moments that make a difference. I was noticed. We were noticed because you had to leave the room.
And it's so interesting during this whole time of COVID too, where so much of it's on telemedicine, right? And so and how often someone will just click off, or they're just doing something else, or whatever that is, and really learning how to exactly communicate what is actually happening for you to stay in relationship.
Yeah. I think that the people who can hold on to that priority, I think there's certain skills that can be taught, like when you walk into the room, or even maybe before you walk into the room, take a couple of deep breaths. Kind of clear all the noise, the acquired ADD that we all have, and just meet the person you're going to see. And I think this is a learnable skill. If you repeat it often enough, it becomes second nature. And then the joy comes back, right? And as you pointed out earlier, it does not take longer. It is about mindfulness, really, and asking ourselves certain questions. You know, let me clear the decks of my busy brain. Let me take a breath between what I was just doing and what I'm doing now. And meet my patient, I and thou, as a person. And the quality of care will be dramatically better, and the healer will be healed, because that's where the joy is. It's in the love.
One thing I always do when I leave a room is touch the door frame. As in the transition, that transitional moment. I'm leaving this room, I'm going into the next. And when I enter the next room, I'll touch the door frame again. I'm entering and crossing into a new threshold. I have no idea who this next person needs some spiritual support, or, you know, final prayers, whatever. I have really no idea until I get into that room. So I treat the threshold as a sacred place. Crossing into, I'm walking into someone's bedroom, basically.
Yeah.
So how do I treat that person? By taking that moment, and my moment is touching the door frame.
And that's an example of something that is totally teachable and generalizable. When I was an intern, my grandfather, who I was very close to, died suddenly. And as difficult as that was, it was a gift to me, because every time an older person from a nursing home with pneumonia and dementia and incontinence rolled in, I could remind myself, how would I want this person treated if he were my grandfather? And it enabled me to remember that all of these people are somebody's grandfather, and that not a demented person with pneumonia and incontinence. And that really, so that trick helped me during my training. Another trick that I'm trying to use with fellows and residents and medical students is, if you are taking care of a person of a different skin color than your own, to always ask yourself, would I be treating this person differently if he or she were white? Because the ways in which we unconsciously judge and distance and impose, it's not conscious. So to make it conscious, we have to practice making it conscious, in order to both protect ourselves and, very importantly, to protect our patients. So these are the types of things that I think are really teachable and could make a profound difference. Touching the door frame, asking how you would want this person treated if they were your grandparent, asking if my approach to this patient might be different if he or she were white. because when you bring it to consciousness, you have a choice about how you act. And you can make the positive, healing, generative, loving choice. If it's unconscious, you can't. So that that's why I think what you teach people to do, the making conscious what's in the unconscious, is really powerful as a mechanism for strengthening healers.
It's a wonderful Zen story, and it's the flip side of your taking care, seeing your grandfather and these elderly patients, and it's seeing someone through grandmotherly eyes. So when you're with a difficult patient, or you're with someone that's with a difficult patient,
or that you don't understand,
someone that you don't understand, say, grandchildren can't do anything wrong. You know, your own daughters and son, you know, they're making mistakes all over the place, but your grandchild comes in screaming and cuts, you know, knocks something over, and grandma usually says, "It's okay, honey." A nice grandma says, "It's okay, honey, don't worry." And the daughter's like shouting, it's like, "Honey, it's just a baby, it's fine." So when we can see someone through those grandmotherly eyes, we see, you know, they're having a difficult time.
Right.
They don't know what's happening to them. They need more information. They need someone to hold them.
Someone just put in the chat about thinking about patients as babies.
Oh, wow.
And I have actually often thought about that in care of people with dementia who often have unrecognized and untreated pain. And then unrecognized and untreated pain manifests as agitation, restlessness, striking out, screaming. And what's fascinating is when a baby behaves that way, what do? We pick up the baby. We check to see if they're hungry. We check to see if they're in pain. We check their diaper. We make sure they're clean and dry. We hold them. We rock them. It is not different. Why do we treat someone with end-stage dementia differently, as if somehow, what do? You give them Haldol. Do we give screaming babies Haldol? No, we don't. We look for the source of the misery and we relieve it. And so I do, you know, the things we do automatically with babies get lost in the way we treat people who are no longer babies. But everyone knows how to do it.
I was talking with a friend.
Let me just interject there, sorry. And what
MG.
I said at the beginning, babies know this when they're born, and they can they teach us. And then we forget, and we grow up, you know, but babies know this stuff.
Yeah.
No, just in the same kind of theme, you know, I was talking with a friend, Ross Gay, who's this wonderful poet and also is going to be involved in the fellowship. And he was saying, you know, we just need to swaddle these clinicians. And what's the fabric? They don't need burlap.
Yeah.
You know, and what's the fabric? What should we weave this fabric to swaddle one another with? You know, because it's that kind of, it feels like also this time, right, has been so challenging for so many of us. And what's always been true is just now right in our nose. And so how do we weave that kind of cloth together as a community of people who care? And so that we can swaddle each other and swaddle the world. And so that actually relieving suffering includes ourselves and is like what you were saying, like it's so precise, like you investigate what's needed. And so, and how do we swaddle with what's really needed? What's the medicine that's really needed?
We're getting some questions. We got the signal that there are questions to be asked. Hopefully they're all for Diane, so we don't have to do more time.
Yes, thank you all. We have collected a few questions in the Q&A as well as in the chat, which I think you've been tracking most of those. So one question in the Q&A came from Natasha, and she said that, Diane, you shared that human connection is the one joyful, nourishing, and inspiring aspect of patient care, and how that's often tossed, in the system. And she also wonders about relationships with colleagues and how those can be strengthened for the same reason, especially for non-palliative care teams that don't have the interdisciplinary team approach.
That is such a great question. And the barriers, the culture of other specialties. So something happened the other day that was really powerful and moving. An orthopedic surgeon from another medical center came to do grand rounds in orthopedics at Mount Sinai about being a Black orthopedist. And he talked about his experience as a Black orthopedist and the ways in which all of the Brownian motion around diversity, equity, and inclusion isn't working. It's performative. It's not making any difference. And you could have heard a pin drop in that Zoom grand round session. And all of a sudden, his colleagues, orthopedists, I have a lot of biases that orthopedists don't talk about feelings. And I'm wrong, totally wrong. That they were so moved by what he said and so distressed by it, and said, we had no, a couple of Black orthopedists in the department who spoke up about their experience within their own department. And it had never been talked about, and they had never been asked about it by their white colleagues or their Asian colleagues. And at grand rounds, they're having this dialogue. So what did it take? It took someone speaking from the heart. And that just totally rebooted the room, totally. So again, we have to make that okay by doing it.
It reminds me of some of the work we've been doing around resilience and working with clinicians and using those Four Noble Truths and really saying, like, just getting clinicians in a circle and saying, tell me about how you struggle. And everyone sharing how they struggle and learning how to create that space, right? To, oh, right, I did. And then afterwards, they were like, I had no idea. I thought you were so strong and invincible and that you didn't have any worries at all. And that we often hide out in trying to perceive or be perceived as fine.
Well, that's the currency of the realm in medicine, right? So, yeah, the permission to be human, I think, can only be given, again, by modeling.
We also brought into the group the janitor, the nurses' aides, the CNAs, and a couple of people in the administration into the group, so they could hear each other's experiences, what the custodian felt, what the janitor felt, what the nurse's aide that comes in, getting paid minimum wage, what their life was about inside the unit. And it's mind-blowing things that could, the doctors say, forgive me, I've never even seen her before. This is the first time I've seen her. She's like, yeah, and I've been here 15 years. So to be able to be that open and that vulnerable is pretty amazing.
Yeah. This is one of the silver linings of Zoom. So because of Zoom, our department has had these what are called town halls that were precipitated by COVID, but everyone in the department, staff and faculty at all levels were invited. And these town halls or meetings turned into, after George Floyd was murdered, discussions about racism. And people were speaking up who would never have a platform in a faculty meeting, because they wouldn't be at the faculty meeting, right? So nurses, secretaries, nurses' aides, all speaking quite freely and profoundly about their experiences. And all the faculty are listening. And so some kind of third wall has been broken, both by COVID and by the crisis in racism in this country, that the illusion of everything is fine is blown up. And that has some advantages.
Questions, Dave?
Yeah, we have a few more. I'm wondering if you're okay to stay a few minutes over for the questions that have come in.
It's okay with me.
Thank you. We have a question from Rebecca, who wrote, I'm interested in how those of us in forensic medicine who deal entirely with deceased patients can be present, quote, after the fact with families or caretakers. Often primary care physicians will not even sign death certificates or seek out our expertise when one of their patients has died, usually at home or in nursing care. And those must be reported to us. And of course, even though we are the last physician to examine the person, their family may not acknowledge that since we have never met them before.
I wonder whether that's a rule. I mean, is it possible for the forensic physician to speak to the family? Because I think that if the family wants to, that could be incredibly healing, that the person's body has been cared
I mean,
for by a doctor. So I wonder what the culture is of forensic pathology in terms of speaking with families and whether there are medical legal anxieties. But I imagine that would bring a great deal more meaning and sense of connection to the human being who has died, to the clinician, if one were able to speak with the family or the loved ones. I don't know if that's possible. It'd be interesting.
Could be incredibly healing, as you said.
and so intimate. The possibility for real intimacy about, like, I've been just taking care of your loved one,
right?
Taking care of their body to make sure they're getting the best care now.
Yeah. I think that's very comforting. It's respect. It's dignity.
Thank you. Elizabeth writes, 30 years ago when I was a medical student, I used to cry copiously when a patient died. This was good, but I lost the ability to cry sometime during residency and have spent decades softening myself again. How do we support our medical students and residents and fellows in staying soft? And she also writes, please note that I trained before work hour restrictions, so that may have been part of it.
Yeah. I think a really important, again, ritual that we can learn and repeat is to talk with our team about the patient as a person who died. Like, what do we remember about taking care of that person? What did we enjoy about taking care of that person? What did we learn in taking care of that person? And palliative care teams do that quite routinely. So there's always a kind of honoring of the relationships with the person who passed. But I don't think it happens routinely in mainstream residency training. And think about the harm of that to the clinicians who witness the trivial way in which the death of a patient is treated.
We have two students who are connected to the center, and before they went to medical school, they said, I want to remember my humanity before I go to medical school. So I'm afraid of what I'll unlearn. And so how do I keep that steady as a practice of kind of crying, actually, when we're sad, when there's something heartbreaking, it's so beautiful to cry. And so to remember humanity.
Yeah, again, I think the not tricks, but the rituals that we've identified, touching the door, thinking to oneself, how would I feel if this person had been my grandfather? They bring us back.
Mm-hmm.
And if we can make a practice of them, hopefully we will be less numb.
And an important part of that I am thou, thank you for bringing that in, is I too will die. And how do I, again, treat this person with respect and dignity, because that is something that I would like. That's something I would expect when I die. So there's no separation between them. We're both, one day I will be in that bed. So I want to be treated the way I want to treat you the way I would like to be treated.
Thank you. And our final question from Bernice, could you explore peri-op staff supporting patients before and after surgery, visiting before and after surgery, and connecting?
Well, I mean, talk about a high stress environment for a patient. Feeling that the people taking care of you see you as a person is the best way to feel safe. Because if you are seen as a person, you know that they will care for you as a person. If you're a body, you're the next procedure, it's terrifying. So the same warmth that you described in the nurse who gave you your COVID vaccine is really powerful and important in the peri-op and post-op setting, because the patient is so vulnerable and so out of control and so frightened. Again, to be seen and met as a human in that situation really makes you feel safe.
Recently, I had surgery myself, and each person, before the surgery came to see me and, oh, do you have any questions? And I said, yes, what brings you joy? And every person was like, what? Like, what? But it was so sweet, because after they were like, what? And I said, I don't know, ice cream? Like, what is it? Mm-hmm. And suddenly there was a connection. And even then they wheeled me in on the gurney and strapped you onto that thing. And I was like, what brings you joy? Because they weren't doing it. So I thought, well, I can approach them. You know? And it made such a difference. And suddenly, by the time I was out, like I felt like there was a sweetness. There was a humanity. And it's, again, doesn't take much time.
Exactly.
And it's totally possible.
Just having the guts to say it.
Right. Yeah. Well, thank you so much, Diane. It's such a joy to be with you.
It's really fun.
We can't wait to see more of you.
Yeah, it's remarkable what can happen on Zoom.
So do you have any closing remarks before I close with people about
Okay.
some details?
Gratitude from me.
For being here. What's, I want to know the dog's name.
Arlo,
Arlo.
as in Guthrie. Yes.
Of course.
Diane, thank you so much. It's been
Yeah.
a real pleasure, an honor to see you again. And to,
Back at ya.
back at you.
And thank you to everyone who joined us. We'll email a recording, a link to the recording of the webinar in the coming days if you'd like to share it with others. And we just want to mention that Koshin, Chodo, and our third guiding teacher, Dr. Taruna Lodog of the Contemplative Medicine Fellowship, as well as Diane Meier and 16 other visiting faculty are a part of this Contemplative Medicine Fellowship. Applications are open for that for physicians, nurse practitioners, and physician assistants. And if you're not in one of those professions, we also have our Foundations in Contemplative Care program and encourage you to check that out. Thank you again for being here, and we hope to see you in an application or at our next Contemplative Medicine Conversation series. And thank you to the three of you for being here.
Nighty night.
Good night, everybody.
Good
Night,
night.
everyone. Oh, good morning. You are. Take care.